Good morning. We're going to start now. For the first conference this morning, I will introduce you to Marie-Pier Roussel. She will be speaking about induced resistance training adaptation in the skeletic muscle for persons suffering from myotonic dystrophy of type 1. Good morning, all.
Donc, ici.
Myotonic type 1 dystrophy, as you know, is a genetic disease caused by an increase in the CTG repetition, an abnormal CTG repetition, and it is a multisystemic disease affecting the muscular, endocrinous, and neurological systems. And with respect to the muscular system, the people suffer mainly from weak muscular strength and atrophy. It was also demonstrated that these problems would lead to diminution to social participation, so we were interested by that. We know that in the literature, physical activity is safe with person with DM1, and it could also cause gains in strength. But we don't know if these adaptation with respect to the muscle or adaptation, neuronal adaptation, or muscular hypertrophy. So to answer this question, we can look at the analysis of the muscular tissues. We know that in most cases, in most populations, neuronal adaptations will take place at the outset. We want to confirm if muscular hypertrophy is possible with these populations because the prognostic implications are completely different. With a neuronal adaptation, we think that patients could reach a ceiling rapidly, while if the true muscular hypertrophy is possible, we would probably see a limitation of the degenerations of the disease. With respect to the analyses of the tissues, we have two different responses. Response to acute exercise or training, so one session. So what we look at then, it would be regulation of muscular proteins. If the fact to have one training session, it would trigger mechanisms equivalent to healthy subjects, that is, to diminish the degradation of the muscle proteins and increase the synthesis, which would signal a possibility of increasing the volume of the muscle. Now, the response to chronic exercise, we want to look at the muscle structure. Clearly, we want to look at the volume of the muscular fibers under the microscope. So we look at the literature, scoping review, as it is called, and we see that the studies looking at the structure of the muscle in the analysis of the muscular tissues using muscular biopsy, and there's somewhat 20 articles dealing with this issue in DM1. Only 3 use this technique, so we're really at the beginning of this research. As regards the balance between synthesis and degradation of the muscle, we look at what happens in acute training. The muscle is always in a balance between, on the one side, degradation of proteins, and the other side, the synthesis. When the degradation is more activated than the synthesis, we end up with muscular atrophy, less proteins, the volume of the muscle diminishes, and on the other side, if the synthesis is higher than degradation, well, we'll end up with a muscular hypertrophy, that is a growth. So fundamentally, we have different markers, different indicators for that. I don't know if you can see here, but we see the AKT markers. It activates the synthesis of the proteins. It will activate mTOR, important marker for us, and also it will deactivate, on the other side, the degradation. It deactivates the two actors here, atrogen and MERV. We'll go back to that in a minute with these markers. let's go back to our questions. Are they neuronal adaptations or muscular hypertrophy? We can look at that in another way in a protocol. We're going to look at the knowledge we have in training physiology, the knowledge we have of that. We're going to look at the temporal degradation of the gains in terms of strength during chronic exercises or training. We're going to assess the strength and the muscular function in more details. It's a classical image here. I'm having a hard time with my laser here. We see the strength gains with time of training and the mechanisms responsible for these gains in strength. So what we see is that at the beginning, the gains in strength 4 to 6 first weeks here in the dotted line, it's more a neuronal adaptation. And after that, we have the hypertrophy, muscular hypertrophy adaptation. So when we train patients, the first gains in strength that we see in the first 4 to 6 weeks, it is mainly due to neurological mechanism. And if we haven't reached a ceiling, we continue to gain strength. Well, this is when we're going to have indications of muscular hypertrophy. So we have set up 2 projects with these data, and we want to look at the response to acute training and to chronic training. We have 2 different interventions. For acute training, it's one only session and resistance training, and we're going to look at the expression of the proteins involved in the synthesis and degradation of the muscle. And as regards the chronic training response, it was over a period of 12 weeks, and we look at muscular strength and functional tests. And a little parenthesis here, we also looked at the structure of the muscle, the volume of the fibers. Unfortunately, results are not available as of now, but if you have questions, I'll be happy to answer at the end of my presentation. Now, we're going to look at acute training. We made a protocol on biodex, like here, 10 series of 12 contractions, eccentric contractions of the quadriceps. The patients really work as hard as they can in order to find as much response as possible regarding the cascades. So we also made a muscular biopsy. The muscular biopsy took place 7 days before. We had a pause, and then we had the acute training test, and 24 hours later we made the second muscular biopsy, and we analyzed the proteins in the muscle. Now, quickly here, we have the characteristics of our subjects, 11 men. We wanted to have only men. Elise will be talking about it later. I don't want to take her punch away from her. Average of age, 49 years of age, IMC 25, and a number of repetitions, about 390. Also here in our results regarding the degradation pathways, we are looking at atrogene and AMERF, coded for the muscular degradation. What we see in our patients, as an average, we see that MERF has diminished significantly with respect to pre-training time. Here, it would be equal to pre-training. Under 1 it has diminished, and over it has increased. So as an average, it diminished significantly regarding MERF. But we see that there's a good heterogeneity with respect to responses between the patients. The great majority of them have diminished. One, it remained almost the same. And for one of them, it increased a little bit. Atrogene, there's less variation. In most cases, it increases a little bit or diminishes a little bit, or nearly the same. MERF is an actor that responds a bit more rapidly, so it's something we could expect after 24 hours after the training session. So regarding the synthesis pathways, we are looking at AKT, activating mTOR. What is interesting here is that patients for which AKT increased, there was also an increase in mTOR. That means that the cascade in these patients is maintained. AKT will do its work to activate mTOR. But there again, there's a good heterogeneity in response. In some patients, it increased very much, like here. I'm sorry, I have a hard time with my laser again. The third patient, we can see that there was 4 times more AKT than with respect to before training session. Same thing in mTOR. As in other cases, it diminished considerably. So in summary, what we can see here is that in response to acute training, some patients will see their degradation pathway diminish, and in other cases, only one, in fact, it will remain the same, and in one case also it will increase. Also, regarding the synthesis pathway, in some cases it will increase. In some cases, one patient, it will remain the same, and in other cases it will diminish. So we see it's very varied with respect to the response to acute training. What we want to determine now is who will respond well to acute training and why. So that's what we want to look at in the future. Now, if we look at chronic training, 11 men, again, adults with DM1, training session of 12 weeks, 6 to 8 maximal repetitions. We had extensions of the knee, abduction of the hips, squat, and foot flexion. Training session working with the inferior members, among other things, because our muscular biopsy method is really located in the inferior members. And we know that the diminution of the strength in the inferior members is quite indicative of limitations in daily lives with persons with DM1. We made a lot of functional assessments also. 30 seconds sitting and standing up, sit to stand, test the stair test, and the walking 10 meters test, comfortable speed and maximal speed, evaluation of muscular strength with 2 different methods. 1 RM, maximum strength that a person can generate in 1 single repetition, and muscular balance sheet quantified by dynamometer, BMQ. That was made at the first week, after 6 weeks, and at the end of the program after 12 weeks. Except for the test of the modified stair test. That was done only at the beginning and at the end. Now, regarding the characteristics of the subjects, some come back in both studies. Average of age is similar, IMC a bit higher, and CTG repetition a bit more. But it is similar than the first one. If we look at the results now, let's start with REM with respect to extension of knees, abduction of the hips, squat, and development of legs. We see there is a significant increase of the strength between the first 6 weeks. What is also interesting is that we see that the increase is significant between 6 to 12 weeks. So as I said earlier, when we have increases of muscular strength beyond 6 weeks of training, we can suspect that's a true muscular hypertrophy, because after that, the neuronal adaptation would have reached the ceiling. So now if we look at the strength of knee extensions, muscle that we worked a lot with in our programs, same thing. We have an increase of the strength that is quite significant between 0 to 6 weeks, and also from 6 to 12. So indications of muscular hypertrophy. And when we look at the functional test, the speed of walking, it increased there again. So it's a better function for these patients. So there's an improvement at the end of the training session. And regarding 30 seconds sit and sat, this too is clearly indicating an improvement, a significant improvement. So it's a test that is very representative of what the patient can accomplish functionally speaking. No different with respect to the modify handstand test, but it is the capacity in the stairways. It's not only, it doesn't depend only on inferior members. So in summary, what we can see is that there's an increase in muscular strength even after 6 weeks of training, increase in the speed of walking and capacity of in the 30-second sit to stand. What does this mean? With acute training, we have various responses that are possible in the regulation of muscular proteins. And what we wonder now about is, are there patients who will respond less than others, and why? So that's what we want to look at with respect to response to acute exercise. Now, with chronic exercise, we suspect that there is a muscular hypertrophy that might be possible after a training session of 2 weeks, and we want to confirm that, as I said earlier, with our analysis of the muscle structure, the volume of the fibers. These results, I haven't presented them, but for some patients, the strength increased much more than others. So there are patients responding better than others to acute training over a period of 12 weeks. For clinicians working with DM1 patients, all patients did not show negative reaction. We have to use our judgment because some patients are in better form than others. Some heart issues can be dangerous and have to be looked at. With respect to the perspectives, in acute training, we'll continue recruiting subjects, especially in order to try and determine who responds well and why to the training session. We're a bit limited in order to respond to that now. And with respect to chronic exercise, we want to analyze muscle structure. We want to determine also the predictive factors to know who responds better and why. Thank you. Ergotherapist at the Bruno Center. Historically, what I have learned with the clientele in myotonic dystrophy is that eccentric contraction were to be avoided. And I have seen that in the study on acute training, the measure was made after eccentric contraction. Any particular reason for that? Well, in fact, what we wanted, we know that in the physiology of the exercise, what has more effect on the cascades for synthesis and for degradation, it's really the eccentric training. That's why we have used this protocol. And now, with respect to the studies in humans, there were no negative effects that were mentioned with respect to eccentric training for persons with a DM1. So it's a long-term program, no danger that a person may have a eccentric contraction. No, the program over 12 weeks confirms that. It is an exercise program, a training program that had concentric contraction and eccentric, and all patients increased their strength after the sessions, so there were no contraindications. Luc Hébert, physiotherapist and a researcher at the CIRIS. Thank you, Marie-Pierre. I congratulate you to have selected a research sector enhancing fundamental research, but with a transfer of knowledge for the clinician. That's new and that's to be greeted. First question, I have two questions. We have targeted the knee extensors, anti-gravitation muscles, functional muscles of great importance. We know that in DM1 often we have distal problems. So you think what you have developed with respect with respect to the extensors could be reproduced elsewhere to confirm the effect of the for the ankle flexion that are often affected. For example, yes, indeed, practically speaking, technically speaking, the quad has been selected because it's anti-gravitation muscle, because our muscular biopsy technique helps us, makes it easier to look for a sample. The training exercises could be adapted for the ankle dorsal flexor. What is more important, more difficult, technically speaking, is to make an analysis of the muscle structure to see if the muscular biopsy is possible. In these cases, we should verify in surgical techniques that were developed. We are going a bit beyond what I'm used to, but we could verify, indeed, if it is possible. But if we think also about more distal muscles, for example, my training program, we looked at foot flexors. Patients had an increase in strength, but I didn't present that. There are many ways to assess RM and plantar flexion, but we think we will have a good technique soon that we will develop. I have one. I could propose it to you. Another question. You indicated clearly that patients are improving with respect to the proteinic synthesis, and that's really interesting because it means that it's very promising. Do you have hypotheses with respect to the profile or the characteristics of these patients that might improve better than others? I know it's coming up, but did you have time to reflect a bit on that? Do you have any hypothesis? Well, in fact, what we had noticed is that, among other things, if we go back to here, the patient, there was one patient for whom the degradation had increased. There was only one that had increased. Degradation had increased. And it is also a patient for whom synthesis had diminished. So if we look back at our characteristics, excuse me, there's quite a few slides here. This patient also had the most CTG in the whole cohort. So it could be an avenue to look at. We'll look for correlation here, but I don't think it's the only factor for explanation. I'm wondering also if there's not also a habit of physical activity or duration of the symptoms. So it's part of many things that we have to look at. Thank you.
Merci.